And the next speaker is Professor Kocer. He's going to share his experience with the FRED.
Good afternoon. I would like to thank you for the invitation. We had a great time yesterday in the hospital, and yeah, I connected. The topic is FRED family and to the Bulgarian family. I like to see all that three societies working together as a same meeting. These are my things up to now and disclosure. The main differences from FRED to the other flow diverters are dual layer stent. It is interconnected to each other. One version for proximal, the other version is distal aneurysm. Also pay attention to the tip. The smaller vessel has no distal tip wire. When I first started to work on FRED, it is in the 2010, and then in 2012, after animal test and clinical the steps, we started to work on the cases. This is the first paper on it. Why I work on FRED? Let me explain to you. This case is done in 2000, 25 years ago. The partially thrombosed basilar artery aneurysm, no collateral at all. That's why we need to protect the basilar artery. The technique here we describe and write is bare balloon-mounted stent as a scaffolding stent from healthy wall to healthy wall. And then in the inflow zone, dual layer cover stent. Don't forget, this is a dissecting morphology, that the cover stent mentality in hyperforating rich area is actually coming from that. And eventually, hemodynamic correction of the basilar flow made the aneurysm spontaneously thrombosed and heal. Look at that, it's the fast healing. And then this is also the long-term follow-up. Patient had no aspirin plavix, no anticoagulation at all. So that is a kind of maybe not dual, triple layer stent mentality in 2000. And then we got the technology in our hands, which was the first braided stent with Leo. And then this is the case showing perfectly how we are using dual layer telescopic mentality in that the awful aneurysm which has a one orifice in it. And this is the first Leo scaffolding, the same mentality coming from the coronary stent experience of us. And then inside of the Leo, there is a second stent which is actually flow diverter is expecting to do the job by itself. Eventually, whatever you put in the brain vessels, if your material adapt the vessel with a nice metal coverage of the neck, it is working. First, we need to stop talking about we have a better clinical, you have a little bit less clinical problem. The problem is how you technically deploy the stent, how you oppose the vessel. It looks like the socks, you know, when you wear it, it should be adapt the leg properly. And this is third month, as the previous speakers mentioned, the aneurysm string in 3 years, the 5-year follow-up. And another the thing you should know about the FRED, everyone thinking that this is an inner marker, the flow diverter is stopped here. It is not correct. The flow diverter is ending here. These are the flare ends and flow diverter is ending here. You see that. These are the markers just below the flow diverter segment. Please pay attention, especially the bifurcation aneurysm. And if you want to protect the A1 orifice and M1 orifice, that is crucial. Okay? Don't trust this part as non-flow diverter part. And then we started to publish our results, either proximal or distal aneurysm. One of the paper that AGNR put it in the cover, and then we publish another longer terms safety, the results of the Fred Jr. And the bunch of papers written on it. I was always in that group, especially in the first publication. The majority of the case belongs to me. And then rumors came. A dual layer stent created a lot of thrombosis, thrombogenic. And then we were shocked and we kind of surprised, but still smiling on it because we are coming to the era on the cover stent and the corner stent 25 years ago, more than that. And we know that certain aneurysm need telescopic stent, and because of that rumors, we publish that posterior circulation and anterior circulation comparison with pipeline and Fred. And then when you check the results, as a multicenter, not the randomized trial for sure, but the multicenter papers, the study showing almost equal of everything. So again, I would like to say that whole stents, all available material in our hands should be evaluated mostly on technical problems, technical feasibility. What is giving us the better, nicer deployment, better, nicer view of the vessels by doing the operation. Like this case, this is a multiple aneurysm case. The left side already treated with onyx certain years ago, and the other side I coiled the distal one. Now I'm deploying the parophthalmic segment. The main differences of Fred is pull and push technique is not working for Fred. That is a wrong technique for us. Instead of pull and push, look at this angle. Look at the microcatheter tip. Deploy certain stents in the middle of the artery and pull back all together with the guide wire and the microcatheter to let the stent open up. Simple. But in reflex, we are trying to separately move the microcatheter and the pusher wire to make it open. That is not correct for Freds. At the curve, if you do this simple maneuver, you will open up at least 90% of the stent without any problem. Of course, this Fred is a braided technology, may have opening problem at the tight curve, especially you oversize it, especially that the vessels is not actually the proper wall and neck, every factors will work for Fred. And then the company follow the surface modification technology, and that's why they create the X technology. This technology is a long history, and we write the first paper, which is the fresh study, and also the American group write the first paper on it. The German centers did a study on it, and a year follow-up also encouraging. But still, we are working on how to reduce the anti-aggregation. But believe it or not, whatever stent I use, more than a decade, I'm using single anti-aggregation if there is no contraindication, which is parasugrel. Single anti-aggregation, all cases, with the proper testing. So the aim is not to reduce the anti-aggregation to 1. I think the aim is to reduce anti-aggregation to a simple aspirin, maybe. Okay? Another advantage of Freds, especially Fred Jr., you don't need to go distal. It is precise. Look at that. This is the location of the guide wire and the microcatheter. No guide wire distally. Deployment is smooth and precise. 1 year and secondary follow-up. Let me show you another complex MCA aneurysm, 3 bifurcation, and the follow-up, the 4-year follow-up, is eradication. Results are the good. Two dual-layer stent doesn't affect the healing reactions in the MCA bifurcation at all. One feature I like to say so, the thread is now prolapsing. 4 millimeter thread, that means the 4 millimeter stent in the artery. It's not 5 like silk. That gives you a precise deployment, precise measurement, less foreshortening. And this is Silk Vista, for example. That's why the guys who use the Silk Vista, that's what I asked to you, has a fear on that and then having a longer stent. This is not necessarily for threads. And then the retrievability and reshootability is also good as silk and another stent in the market. For this blister aneurysm, ruptured one, you can halfly deploy and call it. If you wish, you can deploy it or you can reshoot it. Reshootability is something, but retrievability is something. You can totally retrieve the stent and then use it again. And this is the first year follow-up, third year follow-up. Distal, the only disadvantage is 21 catheter. It was good at the beginning, but the Silk Vista has a bigger advantages because it is using 10 catheter. This is a M4 segment aneurysm location at the deep part of the sylvian fissure, as you see here. And people are blaming that nitinol stent hasn't changed the vessel morphology. That is wrong. It is totally wrong. And you can see the angle change with the Fred Junior, not the Fred. It's nitinol-based stent. While we're talking about things, we should be careful about it. Every stent has an effect of angle change, some of them less, some of them more, but this is a robust, high radial force stent. This is a 30-year follow-up. And I also published that, the distal MCA aneurysm. Another publication came for ACOM aneurysm treatment. This one is one of the first thread case, that the lower one. I will show you the 7-year follow-up of that case. And in such an ugly shape aneurysm, you can do that. Okay, the X flow diverter mentality. I also put another thread for MCA, and I'm following it. Have a look at the flow change in the follow-up. MCA is still feeling, but look at the ACOM. That ugly aneurysm is gone. And then the right flow goes to the left goes to the right. There is no bifurcation there anymore by the help of flow diversion. I'm not saying that you can do it only with thread, but you can do any flow diverter for that one. This case will change your mind, I believe. That is a case, triple times rupture and then triple times treatment, 2 surgery, 1 embolization. In 2011, it was like that, the ACOM. And this is the first operation. They occlude the internal carotid artery. And then the second operation, they clip it. Third one, they coil this one and this one. And in the 10 years, this aneurysm is grown up with a headache. What should I do? That is the residual portion of ACOM, whole left hemisphere feeling from this. And then the right A1 is arising from this. What to do? You may choose the different options, but just trusting the Fred Junior, because it is my baby, you know, I design it, and I know how it behaves in that situation. And then I decided to put the Fred Junior just at the edge of the A1 ACOM junction. I don't want to put any metal on the left. And then come down to cover the right A1. That I did, and this is a year follow-up. Aneurysm is gone. The right A1 distally fed by pile collateral without any infarction. And this is a 1-year follow-up. You can see the Fred Junior there. And also, this is 1-year follow-up, 1.5-year follow-up, 2-year follow-up. That is another example how it's precise. The 5 aneurysm that passed away because of the ACOM rupture. First, I attacked the basilar tip, and then I will attack the bilateral siphon. This is the basilar tip, the stent assistant coiling. And then This is left side fret deployment. You can see that how it can be precise and stay there even though this artery is very enlarged. Because the fret is robust. It is not enlarging more. It is not adapting more. It is not changing the shear stress. It is actually staying there as it is. And that is the location. And this is the right side. Again, I could able to stop just at the edge of the A1 because don't forget, this patient had a fear to have a rupture and that passed away the ACOM aneurysm. The patient has a bleb on the ACOM. I didn't want to touch this. I want to follow it. In the future, I may attack this one. That's why I need the orifice of the A1s. And that is it. That's the bunch of material over there. And let's follow it. 6 months follow-up. The basilar is okay. Look at the siphon. Fantastic the remodeling. The antecordial artery aneurysm is gone. Posterior communicating artery is there. And this is the left side. Again, the fantastic remodeling of that valve. The precise deployment, the stabilization is one of the advantages. My time is over. Let me quick. This is a basilar example, P1 example. One last case for you. People say that you cannot correct the other stent with the nitinol stent. That is not correct for this material. Because of the fear not to cover the basilar tip, the other hospital, they deploy the stent distally, I don't know why, and they also put this stent inside the aneurysm, and then they send the patient to home saying you cure. That is the most dangerous position because you change the flow in the aneurysm, you direct the flow in the aneurysm. You can see that, again, Fred Jr., no guide wire at all. You can see how the radial force, how power of the stent is there. You can able to see that the fret starting here, I'm deploying it, no guide wire. And I'm stopping at the edge of the basilar tip. That kind of precision while you are deploying and that kind of radial force can correct the previous stent. And this is a 4-month follow-up. We are really trying to reach every part of the brain, and we can do it. Not only fret and different material, we have a lot of chance to select. But be aware the technology you are having, and then change your fear according to the scientific knowledge. Thank you for your attention. I hope I can see you, some of you, in China in May this year. Thank you.
Thank you, Professor, for your wonderful, really wonderful presentation and sharing your enormous experience with us. Is there any questions from the room? Can I just ask you something very quickly? You showed the blister 1 aneurysm. One was coiled to the ophthalmic and blister was above it, and you put fret and additional coiling. Do you believe only fret at that time should be enough not to coil it? Because the blister is wrist push coil and halfly deployed fret I saw.
Let me show you why I put the coil there.
Because I think like the coil was exaggerating the size of this blister, and is it not a fragile lesion like they told us?
It is. It is working. Only flow diverter is working. The problem is the Glasgow Coma scale of this case was low. She was cyanotic when she came. And she already came and have a treatment with coiling the proximal aneurysm.
Not the same session?
A month ago.
Okay.
Actually, this is a kind of a lesion that couldn't taken care of in the first session, but I was talking with the family that let's come and do this, the aneurysm, because I didn't like that one. This is a blister location. And then if I could able to coil, I'm always coupling with, because it's give you more proper thrombosis, acute thrombosis by the help of coil. If you cannot, you can, of course, only do the cover stent. At those time, I'm shifting my mind to the silk, for example, to the oversized stent. I would like to touch the blister aneurysm. I don't want to give any gap in between the vessel wall, rupture vessel wall to the stent. That is something you need to have a acute sudden occlusion situation. Here, there is a good enough space for coiling. That's why I coil it.
I personally will be very afraid to put coils there. I
But-
think I will just puncture the blister aneurysms and go out of the sac with the coils.
Look at the stent and my catheter position. You are not pushing the coils towards the aneurysm. You are actually pushing the coils into the parent artery, basically. And then you are supporting your stent. It is a dynamic opening and closing situation there. You are pushing the soft coil towards the rupture point. Your flow divert is already there. Okay? You are ready for it. I understand you.
I trust you completely. In my hand, I never, or my colleagues, if they ask me, let's put a coil, I said, you're crazy.
Believe me, it is much more safer.
I
have to
absolutely
trust
also
you.
Okay.
admire this because as a neurosurgeon, our nightmare are the blister aneurysm, to be honest, is putting a flow diverter in a ruptured case is much better than trying to clip it. We have techniques where you're trying to put cotonate or muscle over it because it will
Yeah.
just tear apart from the artery. So I agree with you that I have
Perfect.
several ruptured cases where I just put a flow diverter. I was afraid to put a coil, but your result is great. I congratulate you, and of course your experience is enormous.
In summary, it is coilable. I'm coiling it. If time to time blister aneurysm, it is not coilable. That this is a classical location. If it is in the ACOM, if it is in the other location, you should only go to the flow diverter, of course.
Thank you once again.